Okay, great. So I was asked to come today to talk about mental health resources, specifically in Arkansas. I'm going to talk about a few national ones, but giving a really broad overview of how to look for mental illness in our perinatal population, but more importantly, what you can do once you've identified somebody who needs assistance. So just disclosures, like she said, I work here at UAMS, and I'll be discussing resources. I have no relevant financial disclosures, but I do work for UAMS and we'll discuss resources that may have that bias. I have put in a lot of resources that I know of that are not at UAMS, but I may have missed some, and I'd be happy for people to reach out if I have. I hear somebody has raised their hand. Is there a question? Okay, I'm going to move on. So just starting off with the why in Arkansas, and I think we're all very familiar with this, but the latest report, which is a little old at this point, did state that 20% of postpartum women report depressed mood or anhedonia in Arkansas, which is higher than the national average that's around 14 to 15%. And I think in Arkansas, women face significant challenges in maternal morbidity. As we know, timely access to care is critical. And given the economic status and the stressors that Arkansans face, depression and anxiety can be at higher rates. My goal today is not just to list the resources, but to give you a clear framework for which resource to use based on the clinical urgency. So the disclosure around that would be is we're not going to go into details on everything around how to identify mental illness, but hopefully give you some high points that you may be able to say, okay, when this is happening, this is what the next step would be. So we're going to discuss emergency versus non-emergency psychiatric conditions during their perinatal period. I think that's the easiest way to break that down. And then the specific mental health resources based on whether it's an emergent versus non-emergent condition. Just to start out with gateway screening for depression and mental health concerns, I know some of the other lectures today, or the next one I think is around screening and intervention, and I think that will be helpful. So this is just a very broad thing. I do think it's helpful even if you're not using a standard screening tool every visit, if it's more of a conversation with your patients of just asking them if they've been bothered by feeling down, depressed, or hopeless, or feeling anxious or on edge for most days. Hopefully this will at least just open the conversation so that you can understand more about how your patient's mental health is doing. We do talk about standard screening tools as well. The two most common is the EPDS and the PHQ-9, the Edinburgh or the Patient Health Questionnaire 9 as screening tools for perinatal depression. It is recommended that we use these screening tools at new pregnancy visits, postpartum visits, and at least one time in between. Both of these are standardized screening tools and have been validated to identify depression during the perinatal period. It is important to know that these symptoms evaluate depressed mood, anhedonia, and other criteria, but they do not necessarily diagnose it. These are still just screening tools. You still need a mental health professional to diagnose a mental health condition. But this can identify people who may be at risk, people who may be struggling, and be able to give them timely access to resources. And I think you're hearing more about this next. So when I think about kind of the clinical triage, I'm breaking this down into yellow flags and red flags. The yellow flags are serious, and require intervention, but the patient infant are not in immediate danger. So these would be non-emergent conditions that we're talking about where they do need help, they need some type of mental health resource, but not in an emergency. These conditions are typically perinatal depression, mild to moderate, perinatal anxiety or generalized anxiety disorder, and perinatal obsessive compulsive disorder. People often miss this one, but this is a condition that can develop during the postpartum period, even in someone who doesn't have obsessive compulsive disorder at baseline. The primary difference between perinatal anxiety and perinatal OCD is the intrusive thoughts that you can't get out of your head. Anxiety comes with intrusive thoughts like, my baby may die. But those thoughts are usually not intrusive to the point that it will take hours out of your day thinking about it, or that you change your behaviors because of those intrusive thoughts. It is important to know because sometimes I've seen clinical scenarios where the intrusive thoughts are quite scary. For example, I had a patient who had intrusive thoughts of sexually abusing her infant, and these came out of nowhere. They were very what we call ego dystonic, meaning she had no intention of doing that. She was very freaked out by it. She did not like having these thoughts, but those thoughts were there. The important part is people with obsessive compulsive disorder rarely act or never act on their intrusive thoughts. They have no intent to do that compared to maybe some psychotic thoughts that can happen that we'll talk about later. So some key differentiators between what's an emergent and non-emergent condition. Not emergent conditions, the patient is distressed but safe. Reality testing is intact, and they're able to care for the infant even if it's difficult. So we do see dysfunction as far as they may not be taking care of themselves as well. They may not be eating as well or showering. They may be feeling very sad or depressed or overly anxious, but they are able to do some basic tasks. Their families are able to get them to kind of be kind of still part of the family and be able to have rational thoughts to some degree compared to emergency situations. So speaking about those, these are psychiatric emergencies requiring immediate action to ensure the safety of the patient and or infant. Conditions that we think about in this category would be postpartum psychosis, severe perinatal depression and anxiety with active suicidal ideation, homicidal or infanticidal ideation, and or severe substance use. So postpartum psychosis, this is definitely a medical emergency. I highly recommend anybody with postpartum psychosis to be hospitalized on a psychiatric unit for evaluation and treatment. And this is characterized by usually paranoid delusions, sometimes hallucinations like auditory. That is actually rare though. Severe confusion and disorganized behavior. I like to describe these patients as they almost look delirious postpartum, where they're just acting very bizarrely. They may be okay one minute, but then the next minute they're not okay, and they may be saying some very bizarre things. They're not sleeping, and they can become very irritable. Severe perinatal depression and anxiety, severe forms are often with suicidal thoughts, and those are considered psychiatric emergencies if you're having suicidal thoughts, especially if there's an intent or plan. And we know that suicide during the postpartum period is one of the leading causes of maternal mortality. Obviously, homicidal or infanticidal ideation, which is very, very rare and most often associated with postpartum psychosis. But this is something that needs to be taken very seriously. And then severe substance use, I think, is also an emergency when people are to the point of having a high overdose risk or not being able to take care of their infant because of their severity of their addiction. We know that drug overdose is the #1 reason for maternal mortality in the postpartum period. So some key differentiators is patient may or may not be distressed. I think that's important. Someone who has postpartum psychosis or severe substance use may not recognize that things are going as badly as they are. They may be unable to reality test. This is very clear in postpartum psychosis or severe depression with suicidal thoughts. They may think like the only way out is to take my life. There's immediate safety concern for both mom and or baby. Usually families are very concerned and will raise the red flag, and providers become very concerned. And these patients are often unable to care for the infant. So I put together just a very quick decision tree, kind of laying this out so that you can say, is this emergent or no, not emergent? So the first question you can ask yourself, is there a risk of harm to self or baby? If that is true, then that is an emergent condition. If it's not true, then it may not be an emergent condition. And is the patient experiencing psychosis? So are they having any type of auditory hallucinations, disorganized thoughts, paranoid delusions, disorganized speech or disorganized thought processes? Those are all signs of psychosis, and those are considered um, emergent conditions. So when I talk about the resources, these are kind of the two questions you can ask yourself to understand, like, which route do I need to go down? So the red flag emergency pathway, I think it's all about safety first. So calling 911, local emergency room, psychiatry consult if it's an inpatient on the postpartum or OB floor, is important. I think for all of the facilities on here, having a pathway, having a policy, having a procedure of what you do when you encounter an emergency situation is important. I get many calls of, hey, I have this patient in clinic and they're suicidal. What do I do? I think having a procedure that your staff can refer to is important. There are crisis lines. The national line is 988. You can call or text. The community mental health centers also have crisis line. For here, it's the Centers for Youth and Family, and the numbers listed there. In Northwest Arkansas and Jonesboro, Arisa Health is the primary community mental health center, and they also have crisis lines. If the patient needs inpatient care, once kind of the evaluation is done, we do have specialized inpatient care here at UAMS on our women's inpatient unit, which is geared for pregnant and postpartum women. Um, People outside of the UAMS facility can utilize the UAMS Transfer Center or Physician Transfer Center with the numbers listed here to get patients transferred to UAMS. And then there is a crisis stabilization unit. This is more, there's not maybe an emergency or there's not an acute safety, but somebody is in crisis and needs help. The only one that is still active is the Craighead County Crisis Stabilization Unit in Jonesboro. So here's a good like pathway in emergency situations. For the non-emergency pathway, I think there's lots of options that you can think about. One is the UAMS Women's Consultation Line service. So there are provider to provider consultation line through the UAMS High Risk Pregnancy Program. Those calls usually typically come to me. So if an OB provider or any provider wants to discuss a pregnant patient and kind of what the next steps would be, they can call the UAMS High Risk Pregnancy Program and they will get you in touch with me and we can talk through that case. As far as ambulatory care goes, here at UAMS, we do have a women's mental health program that specifically only sees pregnant and postpartum women. The access to care is very brief. So I think right now it's 7 to 10 days as when our new patient appointment availability is. And we have a clinic here in Little Rock and a clinic in Fayetteville at the UAMS Psychiatric Research Institute in Fayetteville. Dr. Jefferson started seeing patients there in July. Everyone is trained in reproductive psychiatry, and we have a fellowship program now for reproductive psychiatry. No referral is needed, and patients can simply call our clinic number at 501-526-8201. There is also a Postpartum Support International provider for provider directory, and you can filter it to Arkansas. I have found this specifically helpful for psychotherapy if your patient is interested in that and not medications. That is a great resource that you can go to, plug in the city, and it will give you providers who specialize in reproductive psychiatry or psychotherapy for this patient population. What we would consider warm support would be more national organizations like Postpartum Support International. They have a lot of, they have an Arkansas chapter, but they also have access to support groups, which can be really helpful. There's also UAMS AR Connect, which is a resource that is open 24/7 that patients can call and get plugged in with at least support immediately, but then also provided resources for longer term support. So that's an important resource, and that could be for non-pregnant postpartum women. That's open to anyone in the state of Arkansas. I know Ms. Strabling is going to be talking more about specialized women's services, so I just wanted to put, I did not know that when I made this, so I'm not going to spend too much time on this, but there are programs dedicated to perinatal women with substance use disorders. It's all based on patient location, and you'll hear more about that. Another resource that I want to make sure everybody is aware of is the high risk pregnancy guidelines. So if you go to UAMS and hit high risk pregnancy program, or it used to be called Angels guidelines, there are many guidelines that myself and Dr. Ray, who is one of my partners here in the Women's Mental Health Program, put out around screening, treatment recommendations for various psychiatric illnesses like anxiety, depression, emergencies, opiate use disorders, and substance. So that gives more of here's how you screen for them, here are first line treatments for those conditions, and here are more resources if you want to know more. So just want to make sure everyone is aware of that resource as well. Here are some national resources if you're interested in more information. There's the National Maternal Mental Health Hotline. So that one is similar to the one I talked about where I would walk through a case, but this is a nationwide hotline that you can call 24/7. You can text or call it, and it will provide basic information around perinatal mental health conditions and answer specific questions about that. The Marseille of North America is a national scientific organization for reproductive psychiatry. So if you're interested more in the science behind what's going on with new treatments coming down the pipeline, there's a lot of interesting stuff coming as far as treatment of mental illness, specifically postpartum depression, including some genetic markers that will help predict who is going to get postpartum depression or not with pretty good accuracy. That's kind of like one of the next big things. And then most people know about the hormonal treatments for postpartum depression now. And then there's Maternal Mental Health Alliance, which is a national advocacy organization. So this organization, you can sign up to be on their email listserv, and they really do a good job of sending out alerts as far as legislation and advocacy opportunities in your state or nationally for perinatal mental health. And I think that's the brief overview that I wanted to go over today.